Nice.
Hey, you went to Signal Hill, or you said yours, and it took what, 3 days?
Where's your poster? Over there.
How much is your poster, Kelsey?
And Lionel did it, and it was.
How much is your poster? How much? I got mine done on Oak Hill. I think it's farther away.
Yeah, it's just way better.
We just wanted a research poster.
No.
I don't know.
I couldn't send it.
But I did mine in like hard copy.
Just
Okay. Any questions about abdominal injuries, by the way? Okay. We'll talk about pelvis. It should take us a couple minutes, maybe 10 minutes, and then we'll get into a couple more scenarios. There's a couple there that, again, we can't really do too much about. The one thing that we'll focus on a little bit more is the pelvic fracture, because that's something, there is a skill that we can potentially do on site. Again, with sacral and coccygeal fractures, again, with the spine itself, to play it safe, treat it as a spinal. The only thing I can think of where you would not treat that as a spinal, there's one anatomical difference between the sacrum and the rest of the spine. What's the difference? It's fused. So that's a debate. Do you treat a sacral injury like a spinal? Do you put a collar on and board them? On the CAT exam, I probably would, just to play it safe. It's a fracture. You want to immobilize it. Otherwise, there's no other way to immobilize that than putting them on board. In real life, would you split someone? Sacral. Sacral fracture. That's usually the determining factor. Like a friend of mine just went snowboarding, she landed on a ice, and so she's walking a little bit funny. But our chair, same idea, he kind of hurt himself as well. And no, sorry, not our chair, but another tall guy in our department. He was mountain biking. The same thing happened. But anyways, there's no splint for that. Most of the time, if it's not displaced, if it is fractured but not displaced, they'll just say, you know, walk around with one of those padded donuts, and when you sit for a long time, sit on a donut, so there's no pressure on it. But otherwise, there's no splint, you just have to wait it out a little bit. Okay. So for our purposes, pre-hospital care, there's not much we can do about a sacral fracture, but at least just pick it up and then refer. On the table here, the second one is pelvic fracture. Let's skip that for a second. The next one is testicular contusion, hydrocele and hematocells. For testicular contusion, just like any other bruise, you'll get sharp. Nice facial expression. Pain, swelling, spasm. There is a muscle that determines how low the testicles hang, and that's just mainly to keep the temperature where it needs to be for the sperm to incubate, I guess you will, if you will. With a bruise, though, that muscle will spasm and it'll pull the testicles upwards, and that's painful. So that's something to be aware of. Now, there's a couple techniques that Arnheim suggests. I don't know of any other, but these are the two that typically people use in the field. So if someone gets sacked pretty good and they're in spasm, two things you can do is you can get them to bounce or jump. So just using the gravity to let the boys come back down. The second thing is what most people would do is get the person, the male, to go onto their back and passively take their hips into flexion and extension passively. It's supposed to relax.
That's what I do, yeah.
In a lot of situations, the guy may not want you to touch them. He might be really upset. Yeah. So, but those are the two muscle relaxing techniques that are published in Arnheim's book. Now, if you think of any, it's good to share, but the others are home remedies. Now, how effective these are, there's no research on them, obviously. If anybody would like to do research on these two tests or treatment techniques, by all means.
I don't think that's ethical. I'm sorry. It's not ethical.
With the contusion, okay, so we talked about with contusions. With this particular one, you might get muscle spasm. It's called the cremasteric muscle. And so how to release them, bouncing, or by flexing the hips passively. What you might also get is excessive swelling, and the term for that is a hydrocele. If there's bleeding, you'll see discoloration, and that's called a hematocele. For our purposes, for pre-hospital care, the only thing we can do is ice. Or we can tell we can't do it. We can tell them because I'm not holding the ice bag. So that's for testicular contusion. Now, someone said the word ethics. It is a pretty sensitive area. No pun intended. It's a sensitive area. So ideally, what I typically do, especially if it's a young kid, I tell them to look, and I tell them to feel, and then tell me. And then if it's problematic, I give them the bag of ice, and I tell them just go to the bathroom, just ice it for about 5 minutes, and then take it off. And I tell them it's going to be uncomfortable. So depending on the population you're working with, so the uncomfortable, put a towel in between to cool it gradually. Putting like ice right on top of it, probably not the best thing, unless the person can handle it. Has anybody ever sat in a cold? I think you guys all sat in a cold tub. That's a better option, if they can handle it. Okay, but just realize, and like all joking aside, it is a sensitive area for really young boys. Okay. So any questions about testicular contusions, hydrocells, hematocells? Okay, so again, 2 options: bounce or just flex passively. Penile fracture. Penile avulsion, those are things we can't really do anything about. With the avulsion though, it's just like any amputated body part. Dress the wound of the part that's bleeding excessively.
Reading the lip.
What's that?
Jeff, this is going to be your final review.
What do you do about that, Jeff? It's over there. You need to pick that up. What do you do with the amputated part? Keep it cold. So don't put it directly on ice. Wrap it, and then keep it cold, and then transport right away.
Probably let him a little bit.
Call up Jeff. Jeff, we have a situation. You are our class expert. Okay, last thing is spermatic cord torsion. Again, not much we can do about that. Very painful. It is a medical emergency because if the testicle rotates, you'll pinch off the blood supply. Okay, and that's a problem. Now, we don't go and re-rotate that. I highly suggest you don't. You just refer. Okay. How do you pick that up? They'll be extremely painful. It might be, when you look at the 2 testicles, one of them is going to be discolored. Okay, it's just like if you tie a tourniquet around your leg, there's going to be a difference in discoloration. Okay. It's idiopathic, which means it doesn't come with a contusion. Sometimes just running, and if you're wearing loose underwear, just the bouncing could rotate the testicle, and that's a problem. Okay, it is a medical emergency.
So it's just like pain and no mechanism?
Yeah.
And then when would you just have them like check it out? See
Yeah.
which is colored?
Yeah, just refer. In extreme cases, they'll have to have surgery like if it can't rotate back on its own, then they'll have to have surgery.
Can they like re-rotate it?
I haven't read of any techniques you can use for like for self-derotation, if you want to call it that. I really don't know. Sometimes it just goes back spontaneously.
We were trained in our medical to do it, or just wilderness.
Do you rotate?
You lift it up and see if it will rotate back. So you just do this.
Hold on. Can you do that in front of the camera?
No. Jeff can't know.
You splint a penile fracture?
That's a good question. Because there is no bones in it, so you just So Garen has a suggestion.
Well, we're only allowed to do it if we're delayed access to EMS.
Okay.
Like it's not a first aid.
Okay.
It's more advanced for when you're out in the wilderness and it's
Okay.
going to take a while to get help. But
Yeah.
that's the technique.
Okay, and the rescuer does it?
Yeah.
Whoa.
Wait, say that again?
What do you do?
You go like this.
I'm
make a noise.
cold.
Just like
And doing passively.
This is what Karen is doing, by the way, all you folks that are at home. To derotate a testicle, you do this.
We're not going to post this.
Provide the instruction to the patient to do this to themselves. Let's just say that. Okay.
No, that's in a wilderness setting. If
Okay,
there's
wilderness.
access to EMS, you don't touch it and you send them off.
Okay, do not touch it. Okay, moving on, pelvic fracture. Okay, so there was some information that I wanted you guys to look up. Did any of you read any of that stuff or try to answer the questions?
I read one.
Okay. I tried to make it so that you guys don't have to read the whole article, so I wrote down what sections to focus on. So with the 3 articles, there were some questions. What do authors say? So the first article, you guys do the spring test on your head to toe. You guys have been taught that. People do it traditionally. So what does that first one say? And this is a 2007 article. What does it say about doing the spring test as part of the assessment? Why?
Because you can just cause more damage. You either compress the fracture, or you distract it more.
Yeah. One of the things that happens with a pelvic fracture, if there's blood vessels involved, do you guys remember the name of the plexus in there? Like the it sounds like a fancier term, but it's an anastomosis of the arteries, right? There's a bunch of arteries in there. With a pelvic fracture, you'll separate, and that's where all the hemorrhaging starts. And that's the biggest issue with pelvic fractures, extreme bleeding because of damage to that plexus. They say that the spring, if you get fractured, more likely than not, it'll clot quickly because there's just so many blood vessels there. If you do the spring test, there's a high chance you might disrupt that clot. So they say don't use it at all. There are some people that say maybe use it, but as a last resort. There's other things you can use as part of your assessment to determine whether it's a pelvic fracture or
How
not.
come first aid is between?
What's that?
I think you HCP, CPR first aid, and another one before, or whatever, and it'll hold for testing like this. It's not quite like a spring, but
Yeah.
it's just like you push hard in the pocket,
Yeah.
and then after yeah, if you mark this stop, it's like if someone's fractured their pelvis, like you're like destroyed. You're just sort of wreck everything.
Yeah,
So why do they teach it?
and that's why they don't want you to. I'm not sure basic level stuff, because you guys have more knowledge now. You can do a thorough history taking, consider what happened with the scenario, and then use that as the very last test. And when we teach palpation anyways, how do we teach it? Do you go right in right away hard? You start gentle first and you work your way up. So considering what it says in this article, I probably would do a spring test, but I wouldn't start hard. I try to gather as much information as possible. If I'm still unsure, then I would go in and I would gently go. And if there's a little bit of movement, I would just stop. I wouldn't go in and start rocking right away.
The spring test is just like testing.
So you can distract, or you can mobilize posterior. It's like an AP. If you do an AP, the pelvis actually opens if you compress your closing it. And some people say you should spring test your opening. But that's the way it fractures it, so you don't want to reproduce that mechanism again.
So do you still have AP technicals though? Like, would that be the better alternative? Try to like compress or just open?
That's a good question. Like, should you close it? If it's fractured, would you feel any movement? You might feel some movement. You might feel it like it's
It's
closing.
still painful though, right? So
It might, yeah.
that would be good. They're trying to open it again.
Yeah, possibly.
What about like when they're unconscious and like you're going through like just like the bleed and squeeze, like and you're
Gently.
okay.
Okay, so again, start gentle and then go a little bit harder. But the minute you feel any instability, just stop, because of that fear of disrupting a clot.
What does, like, I've never felt a fracture on my outside, but what does it feel like?
I've never felt one either.
Just a fracture.
Has anybody ever felt like an arm fracture? Like actually felt it? Like, I know a lot of times when you see it, you don't even do any, you don't have to do any of this stuff.
Do we say like peppers or feel like grinding?
Yeah. So the only time I've ever felt an actual fracture is a broken chicken wing. Like you're eating wings and you go like this and it just flimsy. So that's what an arm would feel like, it was broken. If it looks broken, I probably wouldn't do anything. I would just leave it as is, just stabilize, right? But you don't really want to test it. So if they're unconscious and you're not sure and you go like this and it feels flimsy, then you know it's broken. I mean, that's the only comparator I have.
Do you like feel it though? Because like I've had somebody who had like off their shin, and it wasn't really like, it was painful, but it wasn't like that, like it was like a hairline. But you could still feel the compression, like it just kind of felt like it was grinding. Like it just feels uncomfortable.
What does the article say about immobilizing and transporting a patient with a suspected pelvic fracture? So transport and handing over, specifically regarding the log roll. Sorry?
Same as the spring.
Same as
The spring.
a spring test. Yeah, don't do it. Okay, so don't log roll if you can. Don't do that. The better alternative is lifting and sliding. Amount of external compression. What number did they say? Sorry?
Amount of what?
Pressure. Yep, amount of external compression. There's an actual like newtons or pounds of pressure. Okay, so it's about 40, which is a lot of pressure. So 40 pounds of pressure. There are some commercial splints that when you tighten it up, you know it's 40, and it's really tight. The other alternative is a bed sheet, which we have, and you can possibly try, but to get 40 pounds with a bed sheet by yourself is really hard to do.
How much pressure is that? Crank with,
That's 40 at least.
that one's 40?
Yeah.
When they pull it, it clicks at one point, right?
Yeah.
So that's 40 pounds.
Yeah. So they're made based on this research, like those commercial splits. How many of you guys watched them? So Brett, you watched the videos?
Yeah.
Okay, so if you watch the videos, those are two types of commercial splits. So those are catered towards these numbers. Okay. X-rays in the emergency department. What does it say about that?
Didn't say the split on.
Keep the splint on. But what's the problem with taking X-rays with the splint on? Sorry? No, because they're made for X-rays to pass through. You might not see it. False negative. Okay, so what you see is a false negative. It doesn't look fractured because the compression is so much that everything looks perfect. So what do they suggest for those emergency room people? Loosen it up a little bit to see if there's a little bit of a difference, but don't take it off. Because the minute you take it off, the pelvis opens again, disrupt the clot, bleeding. Okay. So that's the fear with the splints, not for us pre-hospital, but when they get to the emergency room, X-raying with that thing still with 40 pounds, it doesn't look fractured.
What do they do for that? Obviously, it's pretty good.
Yeah.
Just for like function things.
Yeah. Essentially. Okay, so that was the first article. There's a lot of information in that first article, so I tried to narrow it down. For the second article, there was a lot of good sections to that. The one we'll focus on for today is the pelvic fractures. So what does the article say about pelvic fractures? Because it says the same thing as the first article with respect to the assessment piece. How do you assess a pelvic fracture? If they tell you not to spring test, what else do you use?
Symmetry.
Okay, asymmetry.
Pain in the pelvis.
Sorry?
Pain in the pelvis.
In the pelvis.
Hip motion.
Hip motion. Pubic symphysis is a good spot to look to see if there's any pain or discoloration as well. In the first article, pain, deformity, swelling, leg length discrepancy, rotational deformity in the lower limbs, bleeding from the orifices. So use that information instead of doing the spring test if you can. If there's any suspicion that you have a pelvic fracture, just splint them because they're going to go to the hospital anyways. Okay. When they talk about mechanism of injury, the main one they refer to is motor vehicle collisions. In sport, aside from like just hitting people, what's another way people can fracture their pelvis? Okay, we'll just put aside the main two. So collisions, so football, hockey, and X Games. Okay, so we'll look, because that's obvious, let's just go with those. Any other traditional sports where you might see a pelvic fracture?
Soccer.
Not as much, but how?
I'm just thinking, like, you guys sprinting for a ball, something one just like, kind of, there's like collide, but they fall on the ground.
Yeah, so collisions. So like football, rugby, so that's collisions. And falls. So gymnast, good. I wasn't thinking about that. That's a good one though. So falls from a height. What's another sport where there's a big fall from a height? This is what I was thinking about.
Javelin? I mean, not javelin. The other pole one. Pole vault.
Pole vault. They missed the mat. It's happened before.
I fell.
Right.
How high do you jump when you throw the javelin?
I haven't seen that video.
You're like a Spartan.
The javelin judge that hits it right in the gut.
So, so what I've heard from pole vault and fractured femurs and fractured pelvis, if they miss the match. How high do they go? Pretty high. So that's something to be aware of if you're working track, especially if you're working field events. Stuff could happen. And then they say with pelvic fractures again, circumferential compression using a bed sheet or commercial split. So they say the same thing as the first article. But they add to that, tie the lower limbs together as well. Okay, don't bind them tightly together, but just move them together and then tie them. Any questions about that second article? Okay, the third article, they actually tested the device. So this is the teapot, and there was a video on the teapot. How was the immobilization device applied? And there's some information there that you could use even if you're using a bed sheet. So how did they apply the device? It was in the method section.
First hold the greater
Good. In the video with the, I didn't put a bed sheet video, but sometimes when it's demonstrated with a bed sheet, they typically don't tell you to landmark that level. When I've seen the bed sheet videos, it's the entire pelvis. Okay? So what you want to stabilize, and this is the important one when you're putting a pelvic splint on, is level of the trochanters and pubic symphysis. That's how low you want to be to actually stabilize the pelvis appropriately. If you push on the iliac crest up high, it'll naturally open up lower down. Can you guys picture that? If I squeeze here, it'll open down there. What you want to do is keep the pubic symphysis together, because that's where the fracture occurs, there or at the SI joints. Okay. So grade level of the trochanters and make sure the hips are internally rotated, not externally rotated. Because what happens when you externally rotate? The pelvis opens. Okay. So those are two key things to keep aware of when you apply a pelvic splint. 40 pounds of pressure, level of the trochanters, internal rotation at the hip. The last question is, what are some of the complications with applying this particular commercial splint and many commercial splints? There's one. It's not a major complication, but it's something to be aware of because the patient might complain afterwards.
Pressure sores?
Pressure sores. It's 40 pounds, that's a lot. Okay, if you take a weight belt and you put it on as tight as you should wear it when they tell you to put on a weight belt, but put it on even tighter than that. Yeah, so those of you who worn a weight belt before, you normally put it on tight, but imagine it being tighter for the purposes of holding a pelvic fracture together. So that it's pretty tight, and as a result, people get pressure sores or blisters from the device. Now, is that a big problem? Not right then and there, because the more important thing is the pelvic fracture. People can die from the pelvic fracture because of the amount of hemorrhaging that can take place. Okay?
Did you use a weight belt?
You could. That's the alternative. I would use a weight belt before a bed sheet. Yeah. Yeah. How do you put it in? Because on the one video, they actually log rolled,
Yes, not bad.
folded it, put it in, and log rolled back. Okay, so they folded the splint, log rolled, slid it in, log rolled back, and then they pulled it out underneath the bum. How do we put it in?
You also done like sliding kind of underneath the legs.
Good.
Just shimmy it up.
Shimmy it up. So use the natural curves of the body, underneath the low back, underneath the knees, and then just, I use the word floss to the level of the trochanters, and then okay. Well, good. Any questions about pelvic fractures and how to manage those?
What were you did post the bed sheet. What was the
Yeah,
problem?
Good question.
They were moving, like they were just reefing on him. He was all over the place.
Yeah, it was too much movement, and it wasn't trochanters only, it was like the whole thing. They were trying to apply as much pressure as possible by just twisting. I mean, that's a way to tighten it, but it's not accurate. But the way they put it in was really not stable.
What would the top back there? Is it kind of jammed in there afterwards?
So you like, yeah.
I would question whether that really holds or not. But at the end of the day, if that's all you have, that's better than that. How can you tie it up a little bit? Don't wobble the person all over the place. Put it underneath the bum or the back and then shimmy it, and then make it more narrow than wide. Narrow around the trochanters, but not wide across the entire pelvis. So fold it a little bit more so it's on the face. Okay. Any questions about pelvis? Okay. We'll do one scenario, and we're done. Okay, so in your groups, let's have one more person, and we'll have 4 people outside, and we'll set up the next scenario for you. Okay.
I want to try something.
Do you guys have a thing?
No.